ஸ்டார்டிங் இன்ட்ரடியூக்ஷன் ஒரு ஸ்பீக்கர் பேசும்போது ஃபோட்டோஸ் நான் அவங்களுக்கே ஒரு எவிடன்ஸ்னால் நான் அனுப்புவேன்.
அதிராங்கிட்ட சொல்லிட்டு சஞ்சனோட சொல்லிடுவா
இன்ஃபார்ம் பண்ணிவிடுங்க. வெறுமனே அங்கே மட்டும் எடுக்கிறது இல்லை, அவங்க ஃபோனில் ஸ்க்ரீன்ஷாட்டு ஏதாவது ஒன்று யூஸ் பண்ணுவேன்.
ஃபோட்டோஸ் ஸ்க்ரீன்ஷாட் எடுக்க சொன்னாங்க. இப்போ இதாகும் இல்லைங்களா லைவ் இது அது ஸ்க்ரீன்ஷாட்டு இல்லை ஃபோட்டோ எல்லாமே இன்ட்ரடக்ஷன்லேருந்து அதுதான் இன்ட்ரடக்ஷன்லேருந்து நிறைய கிளிப்ஸ் எடுக்க சொன்னாங்க. எது தேவையும் போட்டுக்கலாம்ன்ற மாதிரி சொன்னாங்க. ஓகே அதுதான். சொல்லியாச்சு மேம், சொல்லிட்டேன் மேம், சொல்கிறேன். ஃபஸ்ட்டு நான் உட்கார வச்சிடுறேன் எல்லாரையும், உட்கார வச்சுட்டு அதுக்கப்புறம் நான் எடுத்துடுறேன் எல்லாத்தையும். ஹலோ
Good afternoon, sir.
I thank Dr. Bhuvneshwari given this opportunity to share my knowledge to my gold teaching institute. My previous institute was Tagore Dental College. Okay. Before was the man is the
Chitra madam.
yeah. Chitra ma'am was there. Okay. She is very supportive. Okay. The same after a long time I'm seeing the same lecture hall where I taken classes for 10 years back.
We
I'm
welcome you
very
to
happy.
lecture hall, sir.
Yes, ma'am. Thank you, ma'am. Thank you, ma'am. Can move to the session now?
We will present this slides.
Okay, next. Ma'am, you are sharing the PPT or I have to share? PPT, ma'am?
Sir, I think you can better present, sir. I think some problem here. Say. Sir, I think you can better present, sir. I think some problem from here.
Sir, kindly unmute, sir.
Hello. Hello. It's audible?
Sir.
Hello.
Yes, sir, it's audible, sir.
Yeah, okay.
But the presentation has now closed, sir.
It's not visible.
Now it's not visible, sir.
It's visible?
Yes. No, sir.
Oh, it's okay.
Yes, sir. Now it's visible, sir.
Yeah.
Thank you, sir. Yes, sir. Audible and visible, sir.
Yeah, 1 second. Good afternoon to everyone. Just I'm presenting today as a periodontal medicine. Before going into periodontal medicine, first we have to know what is focal infection theory. The focal infection theory is any diseases in the local site. Okay, any disease in the local site that spread through the circulations. Okay, that leads to diseases in the distant sites. You can see here any infection in the teeth or tonsil or sinus. Okay, that crosses that microorganisms.
Sir, sorry to interrupt, sir. Again, the presentation is not visible, sir.
It's not visible.
Yes, sir. It's visible, sir. Yes, sir. Thank you, sir.
So, first you have to know what is focal infection theory. Focal infection, you know that any infection is caused by the microorganisms. Okay, so whenever the infection in the local site, okay, that local infection causes diseases in the different sites of the body is called as a focal infection theory. You can see here the teeth or tonsil or sinus. Okay, the local infection in the particular teeth or sinus or tonsil that crosses into the different sites through the bloodstream, okay, and causes diseases in the lung or heart, okay. That is called as a focal infection theory. You can see that what are the methods of spreading a local infection into the different parts of the body. Okay. There will be a through the microorganisms or through the bacterial products or through the inflammatory mediators. Based on that, it is classified into metastatic infection or metastatic injury or metastatic inflammations. Okay. So we're taking is a metastatic infections. Okay. The infection is due to the microorganisms. Okay. In case of the periodontal disease, the microorganism from the periodontal disease enter into the circulation and reaches in the different areas of the body. So we're taking as a Frietium lobotoid, you can see the three gingivalis and Fusobacterium nucleatum crosses the placenta and causes infection in the placenta and causes premature contraction and causes the Frietium lobotoid. Okay, so in case of metastatic infection, it's called as a due to the microorganism from the local site, it enters into the circulation and reaches in the different parts of the body and causes the diseases is called as a metastatic infection. Okay. Next one is the metastatic injury. Metastatic injury is the bacterial products. It's due to the bacterial products or toxins. Okay. If taking as a P. gingivalis, it contains the gingipains, and AA it contains the leukotoxin, and also if you're taking as a periodontal microorganism, it's mostly a gram-negative microorganism. It cell membrane it contains the lipopolysaccharides. So these toxins enter into the circulation and reaches to the bloodstream and reaches to the different spots of the body that will cause the diseases. If you're taking as a P. gingivalis, gingipains, it is increase the risk of the cancer and also increase or worsen the already present cancer. Okay, and also is a lipopolysaccharides. Okay, lipopolysaccharides it will be present in the all gram-negative microorganisms. Okay, that will increase the risk of infective endocarditis. Okay, so the metastatic injury means the diseases is due to the bacterial toxin and the bacterial products. Okay, next one is the metastatic inflammations. Here the inflammatory mediators, the localized produced inflammatory mediators that reaches the different parts of the body and causes the diseases. Based on that, it is called classified into metastatic inflammations. Okay, so the focal infection may spread through either metastatic infection, injury, or inflammations. Okay, now we come to the periodontal medicine. Okay, what is meant by periodontal medicine is the periodontal diseases. Okay, the periodontal diseases that cause or worsen the systemic diseases is called as a periodontal medicine. Okay, the periodontal medicine is a study of causing a systemic diseases or worsening the disease in systemic diseases is called as a periodontal medicine. Okay, so what is the systemic diseases is caused or worsen the periodontitis? You can see that cardiovascular diseases, endocrine system, reproductive system, and respiratory diseases, and also the cancer. So whenever the periodontitis is present, okay, that will lead to increase the occurrence of cardiovascular diseases, endocrine system, reproductive system, respiratory disease, and also the cancer. So why periodontitis is one of the risk factor for the systemic diseases is the teeth is the major reservoir for the colonization of the microorganisms because 1 gram of flour contains the 2 into 10 to the power 11 number of microorganisms. Okay, so a small amount of flour contains a lot of microorganisms, and you can see that mostly the gram-negative microorganisms. You know the gram positive and gram negative. Gram negative is the highly virulence compared to the gram positive microorganisms. Okay, so from here, periodontal disease, the microorganism easily transmitted to the other parts of the body. Once the microorganism is colonized on the tooth surface, makes the junctional epithelium. It's preventing enter into the periodontal tissue. Junctional epithelium is a barrier. It acts as a barrier. Okay, that will prevent entry of microorganism in the periodontal tissue. Okay, so what happened here? Microorganisms leads to the inflammation of the gingiva that will leads to the breach in the junctional epithelium. There will be ulceration and inflammations through the ulcerations, microorganisms enter into the periodontal tissue. From the periodontal tissue, the microorganisms enter into the circulations, okay, that will lead to the systemic diseases. So the microorganisms enter through the systemic circulation through the ulceration in the junctional epithelium and also in the ulceration in the junctional sulfur epithelium and junctional epithelium. Once the microorganism entered and inflammation will occur. Okay, so whenever the tooth is colonized by the dental plaque, the immune cells come and fight with that microorganisms, fight to eliminate the microorganism and bacterial products. Okay, when the immune cells failure to eliminate, okay, due to those inflammatory reactions, when the immune cells failure to eliminate the microorganisms, that leads to destruction of the immune cells and also production of the cytokines, prostaglandins and matrix metalloproteinase. Okay, so the host immune cell reaction produces the cytokines, prostaglandins and matrix metalloproteinase that causes the destruction of the collagen and also the alar bone that will lead to the clinical signs of the diseases. The cytokines is there, the cytokines are prostaglandin and MLPs. These will enter into the systemic circulations, okay, that will lead to the diseases in the different parts of the body. Okay, so first one is the here the microorganism enters into the systemic circulations, okay, and here the inflammatory mediators produced by the periodontal disease enter into the systemic circulations, and also the bacterial toxins also enter into the systemic circulations. Okay, this is the three ways, okay, from periodontal diseases causes the systemic diseases. We can see here the bacteria, okay, the bacteria and all the bacterial products, right, and toxins, okay, and inflammatory mediators. Thus, these three are entered into the circulation, okay, and transmitted through the blood circulations and enter into the different parts of the body, okay, and also lead into the cardiovascular diseases, okay, and free-term low birth weight respiratory diseases. So today we will see two, okay, diabetes and preterm low birth weight. How the periodontal diseases affect the diabetes and also periodontal diseases lead to causes the preterm low birth weight. What is diabetes? Diabetes is a increased blood sugar level. Either it's due to deficiency in the production of the insulin or the cell resistance to the insulin. Okay, so insulin is the main hormone that regulates the blood sugar level by enhance the entry of glucose from blood into the cells. Okay, so whenever there is a insulin resistance present, that will lead to the insulin uptake of the cells will be affected. That leads to the glucose level will be increased in the circulation, that leads to the diabetes and diabetes complications. Okay, the diabetes is mainly due to the three types. Okay, type 1 is a insulin dependent diabetes. Type 2 is a non-insulin dependent diabetes, and 3 is a gestational diabetes. Type 1 is due to the deficiency in the production of the insulin. Type 2 is due to the insulin secretion will be normal, but the cells having resistance to the insulin, so that causes cells uptake of glucose will be affected, that leads to the diabetes. Okay, in case of gestational diabetes, it is commonly occurs during the pregnancy. What are the complications of diabetes? Let's see the retinopathy, neuropathy, nephropathy, atherosclerosis, and halted wound healing. You can see that 60 complications of diabetes is a periodontal disease. Whenever there is a diabetes is present, that will increase the disease of the periodontal disease. Periodontal disease. Okay, so diabetes and periodontal disease are a two-way and bi-directional relationship. Either periodontal disease is present, that will increase the occurrence of the diabetes mellitus, and also whenever diabetes mellitus is present, that will worsen the periodontal destruction, that will lead to the periodontal disease. First, we will see the what are the role of diabetes to the periodontal disease. Okay, so whenever there is diabetes is present, we can see that there will be altered colonization of the microorganism in the tooth surface, and also we can see that altered immunity, and also you can see that aging, altered collagen metabolism. Okay, these three will causes increased periodontitis whenever there is diabetes present. Okay. First, we will see what happens in the microbial colonizations. Okay, whenever the blood sugar level is increased, that leads to the increased GCF level of glucose. Okay, so whenever there is a GCF level of glucose is increased, that may leads to the increased colonization of microorganism because it provides the nutrients. Okay, so it will change environment in the tooth surface. Okay, so that will leads to the increased colonization of the microorganism will be present whenever diabetic patient is present. Okay, next one is the halted immunity. We can see that halted chemotaxis and phagocytosis is commonly associated with the diabetic patients. Okay, so the immunity was affected in diabetic patients. Okay, and also there will be increased MMPs and decreased collagen synthesis. Okay, and also increased oxidative stress that leads to the increased periodontal destructions. So that leads to the periodontal diseases commonly occurs in the diabetes mellitus. Okay, and last one is the advanced accumulated glycated end products. Okay, AGE is formed by combination of the protein and glucose combinations leads to formation of accumulated glycated end products. Okay, what is the accumulated glycated end product? Is the formation combination of the protein and also glucose leads to formation of this AGE. This AGE interlinking with the collagen fibers, it it's formed the irreversible collagen. The irreversible collagen means normally collagen metabolism, normal formation synthesis of collagen and degradation of collagen normally occurs. What happens here? Due to the AGE formations, the normal degradation of collagen will be affected, and also the synthesis of collagen also will be affected whenever there is AGE formation is occurs. So, whenever the synthesis of collagen is occurs, that leads to the normal repairing capacity of the collagen will be affected. That's only you can see commonly. Diabetic patients having poor wound healing. Okay, and also periodontal diseases. We taking as a periodontal diseases. The dissection of the periodontium is not a continuous process. There will be a period of dissections and period of repair or will occurs. What happens in diabetic patients? The period of repair will be disturbed. Okay, and that will lead to the periodontal dissections will be occurs more in the diabetic patients. Okay, these three lead to the periodontitis. One is the change in the local environment of the tooth that leads to the increased colonization of the microorganism. Second is the halted immunity, and third is the halted collagen metabolism. These three leads into the increased periodontal dissection and leads to the increase the formation of the periodontal disease. Now we can see the what is the role of periodontitis on diabetes. Okay, so we already 1 second. So we already discussed what is the normal pathogenesis of periodontitis, how the periodontal destruction was occurs. We can see already saw that. We can see that there will be increased colonization of microorganisms will be present, and also there will be inflammatory mediators will be present for periodontal destruction. Same thing happened here. Here you can see that. So periodontal microorganism enter into the circulations, and also the bacterial products like endotoxins will be enter into the circulations, and also there will be increased the inflammatory mediators in the circulations. So whenever there is a periodontal diseases, there will be increased circulated microorganisms and bacterial products, and also the inflammatory mediators. Okay, that will leads to the causes the resistance of the cells to the glucose. Okay, so insulin resistance of the cells is present. That will lead to the cells won't uptake the glucose. So glucose will stay in the blood. That will lead to the increased diabetes occurrence in the diabetic periodontitis patients, and also the worsen the glycemic control of the periodontal patients. Okay, so what we have to do is whenever treating the periodontal diseases, okay, by scaling or root planning, by reducing the microbial colonization. Scaling or root planning reduces the deposits of the tooth surface. It will reduce the microbial load, and also whenever microbial load is reduced, okay, the inflammations will be reduced, the inflammatory cytokines will be reduced, so that will leads to the reduced insulin resistance to these cells, okay, that will leads to the good diabetic control will be present, and also reduces the diabetic complications to the patients. So, along with the scaling and root planning and periodontal surgeries, we have to combine with the doxycycline and tetracycline for 2 weeks, and STD of minocycline 20 mg for 3 months will improve the glycemic control to the patients. Next, come to the preterm low birth weight. Okay. So, what is preterm low birth weight? Whenever the baby is born before 37 weeks of gestation, or when the baby is born less than 2,500 grams, that will causes low birth weight. Okay. So, it's most commonly is due to the smoking, diabetes, or advanced maternal age, and poor socioeconomic status, and also the bacterial genosis. It is important thing is the bacterial vaginosis is the main factors for causing the preterm low birth weight. Okay, whenever dysbiosis happens in the vagina, okay, that will leads to the infections and inflammations. That inflammatory mediators causes rupture in the uterus membrane, that will lead to premature baby. Okay, so and also last one is periodontal disease. Periodontal disease also one of the risk factors for preterm low birth weight. Okay, we can already see in the pathogenesis of periodontitis. Okay, it's having mostly the preterm low birth weight. Most commonly we can see the amniotic fluid. We can see Purpuromyces gingivalis and Fusobacterium nucleatum will be increased in the amniotic fluid compared to the normal patients. Okay, so this is the periodontal pathogen. Purpuromyces gingivalis and Fusobacterium nucleatum is the periodontal pathogen, is commonly associated with the preterm low birth weight. Okay, so whenever there is a periodontal disease, okay, the microbial pathogen will enter into the systemic circulations, and also the products of endotoxins and lipopolysaccharides also enter into the circulations. Okay, that will process the amniotic placenta and enter into the amniotic fluid. Okay, that will leads to the inflammation and infection in the placenta. Okay, that will leads to premature contraction of the uterine. That will lead to premature baby. Okay, and second one is the inflammatory mediators, and also locally produce the inflammatory mediators. Okay, the inflammatory mediators produced in the periodontal sites like prostaglandins, TNF alpha, and that will enter into the systemic circulations. That is also crossing the placenta, enters into the amniotic fluid. That will also causes premature uterine contraction, and also that will lead to premature birth. These are the two mechanisms will causes the preterm low birth weight. Is a flowchart, the same thing. Flowchart saying the same thing. There will be increased bacteria and inflammatory mediators, and that will causes the premature contractions and preterm labor. What is the treatment for pregnancy patients? If your patient is healthy, okay, if patient is healthy, there is no periodontal diseases is present, they have no need for treatment, but we normally have to give the oral instructions and educate the patient about importance of oral hygiene. Okay. Next one is whenever there is a gingivitis is present, okay, we can go for oral hygiene instructions and educate the what is the importance of the maintaining the oral hygiene, and also we can go for scaling and polishing to reduce the microbial load. Okay, it will reduces the occurrence of the preterm labor. And last one is the periodontitis. Whenever there is a periodontal disease is present, okay, so we have to treat that periodontal diseases. Okay, we have to go for oral hygiene instructions, okay, scaling, polishing, and also we can go for root planning where the periodontal diseases are affected. Only a tooth is affected by the periodontal disease, we can go for root planning in the second trimester period of the pregnancy. Okay, this will reduces the microbial load and inflammatory mediators in the circulations, that will reduces the preterm birth of the baby. From this, I concluded that whenever there is a periodontal disease is present, we have to educate the patient what is the importance of maintaining the oral hygiene, okay, and also treating the periodontal diseases prevents the occurrence and control of the systemic diseases. Thank you.
Thank you so much, sir.
Thank you.
I hope
Any doubts, no?
student side, any doubts? I think the students should have understood the importance of the link of the diabetes as well as the preterm low birth weight, which is a frequently asked essay or as a short note. So thank you, sir. Thank you for giving the insight into these topics.
Thank you. Thank you. Thank you.
So now we move on to the next lecture from Dr. Nandita ma'am. So who is a professor and head in Asan Dental College. So her topic today is local drug delivery, and she's a long-time friend of mine. Nice having you here with us in this Periyodarshan series, Dr. Nandita. And she has already spoken for Periyodarshan for the past few years. We welcome you. Say, podium is yours, Doctor. Nice meeting you, Doctor.
Thank you, Dr. Bhuneshwari. Very good afternoon to everyone. And thank you for the introduction. Am I audible?
Yes,
Am I audible?
Yes, yes, you're audible.
Okay. Can I just share my screen? One second.
Yes.
Is my screen visible? Hello?
Yes, Doctor.
Are you able to see the PPT? I'm not sure.
Yes, yes, we can see the PPT.
Okay. Thank you for the introduction, Dr. Bhuneshwari. It's a great pleasure actually to be meeting you all once again for Periyodarshan 2025. First and foremost, I would like to thank a few members. Ms. Rakshana, Trust Member, Professor Dr. Mala, Chairperson, Mr. Manikandan, Secretary, Dr. Venkata Krishnan, Principal, and Dr. P. Sai Krishna, Vice Principal of Tagore Dental College for giving me this opportunity. And of course, my colleague and friend for many years, Dr. Bhuneshwari, for giving me this opportunity on this platform. So today I have been asked to present on local drug delivery systems, and before I move on, a small introduction about myself. So I am currently the professor and head of the department of Asan Memorial Dental College, which is a private college in Chengalpet. And this is few of the cultural activities which we have done recently in Assam. So thank you once again. And moving on to today's topic, we're going to see on local drug delivery systems. So I think most of you will be familiar by this time because you're approaching your exams shortly. And local drug delivery systems, as the term itself suggests, usually refers to drugs which are placed in a local place, that is within a particular site. And if you look at periodontal disease as such, that is periodontitis, it is mainly characterized by the presence of inflammation and clinical attachment loss. So this clinical attachment loss itself will manifest either in the form of a pocket or in the form of recession. So when there is a periodontal pocket, it is very difficult for systemically administered drugs to reach that depth, that is to reach the depth of a periodontal pocket. So that in that context, there was an idea to use something which can be delivered directly into the periodontal pocket to give the maximum benefit. That is how these local drug delivery systems came into practice. Because of the limited efficacy of mouth rinsing and irrigation in deep periodontal pockets, an alternate system was looked for, and the main aim of this local drug delivery system is to maintain the antimicrobial agents within the infection site. So, infection site here refers to the periodontal pocket, and to maintain an effective level of the drug for sufficient period of time without producing any of the major side effects which are brought about by the that is use of systemic antibiotics. So the indications for local drug delivery system is it's used as an adjunct. So adjunct means a combination therapy, that is monotherapy and an adjunct therapy. These are two different terminologies. Monotherapy is basically your single line of therapy. It is usually referred to as the conventional therapy. If you look at periodontal pockets, the conventional therapy that we do is scaling and root planing. Using scaling and root planing, most of the pockets reduce, but there are few instances where it is not just enough with scaling and root planing. That is, there is not much of an efficacy that is obtained after scaling and root planing. In such cases, we use an adjunct, that is an product which is used in conjunction with the conventional therapy in order to provide or produce a more beneficial effect, which is called as a synergistic effect. So when two things combine together, it produces an effect which is far more beneficial than the usage of the single therapy. Okay, so local drug delivery is not a monotherapy, it is always used as an adjunct. It is used for treating either localized non-responding sites in a controlled patient, that is patient who is usually responsive but few areas are not responding to conventional therapy of scaling and root planing. And most often if you see, local drug delivery is used in failing implant cases, especially when the patient is having peri-implant mucositis or peri-implantitis. We use a combination of scaling and root planing along with local drug delivery agents. It's also recommended in patients who are medically compromised, where surgical procedures cannot be done. In patients who are having periodontal abscess, and it's also a major part of periodontal maintenance therapy. So by this time, all of you will be knowing that patients who are having periodontitis are lifelong maintenance patients. So when we do maintenance therapy, we usually repeat the process of scaling and root planing. In some cases, it might be necessary to use an adjunct as part of the maintenance therapy when we can use local drug delivery agents. Also, we use it in patients who are having gastrointestinal intolerance, because when you give systemic antibiotics, the gut bacteria are affected, and usually patients who are not having proper gastrointestinal tolerance might find it difficult to eradicate the drug from their body. So in those cases also we indicate local drug delivery systems. Now the contraindications are in patients who have a history or allergy for a particular antimicrobial agent. Similar to drug allergies for systemic antibiotics, if the patient is allergic to a particular drug, it is advisable not to use it even in a localized format. And patients who are pregnant and lactating, children who are under the age of 12 years, it is not indicated, and patients who are having complete renal failure, because it is very difficult to discard off the drug, and patients who are susceptible to infective endocarditis. Now this, you might ask why antimicrobial agents should not be given to patients who are susceptible to infective endocarditis. It is mainly because the procedure involves placing the drug within the periodontal pocket, that is in deep periodontal pockets. Now when you place the drug, the procedure itself might cause bacteremia, which might result in development of infective endocarditis, and that's why it is contraindicated in those who are having susceptibility to develop infective endocarditis. Now moving on to the advantages. If you compare systemic and local drug delivery systems, the advantages are very easy to identify. One is you are able to achieve a very high concentration within the subgingival areas, that is within the periodontal pockets. Now, this we are not able to achieve with systemic therapy because systemic drugs cannot reach deep inside the periodontal pockets, due to which they do not have much of an efficacy without scaling and root planing. Okay, so if the condition involves periodontal pockets which are deep, it is better to use a local drug delivery system because you will get a high concentration of the drug within the site. Secondly, it does not require patient compliance. Now, patient compliance is needed when you give systemic therapy because the patient has to follow a particular regimen. If they are asked to take the drug for 3 times a day, they have to follow that properly. In case they forget or they fail to take the drug, the efficacy is not obtained. But in the case of local drug delivery systems, most often they are professionally administered, so it does not require patient compliance. Of course, this is a disadvantage also. We'll see in the next slide how it acts as a disadvantage also. And it does not harm these symbiotic useful microflora of the gastrointestinal tract, and systemic intolerance is bypassed. So if the patient is not able to take drugs systemically, it is better to provide them with the local drug delivery systems. Now, the disadvantages mainly involve the placement of the drug because it is technique sensitive. It requires expertise to place the drug properly into the pocket depths, okay, in order to reach a proper therapeutic concentration. And if it is being placed by the patient themselves, then it requires good manual dexterity. That is, the patient should be having good dexterity in their hands in order to place the drug, that is, to use the irrigation systems or the local drug delivery systems properly. And that again requires patient compliance. So, this is both an advantage and disadvantage. If the drug is placed professionally, it is an advantage because they do not need any patient compliance. If the drug is placed by the patient themselves, then it requires patient compliance. And also, complete drug penetration is not possible within deep pockets. And if there are a lot of pockets in a particular area, that is, if the entire quadrant is affected, then local drug delivery systems are not usually advocated. So the main intention of using a local drug delivery agent is as an adjunct to scaling and root planing to control the bacterial growth in that particular pocket area. So they have found out that when these local drug delivery agents are placed into periodontal pockets, there is a significant reduction in the subgingival microflora, which means the subgingival bacteria are definitely affected. That is, there is a reduction in their numbers, and also the clinical signs of inflammation. And because of the reduction of bacteria, there is a repair mechanism which occurs, leading on to decreased probing pocket depths. Um, the American Academy of Periodontology has stated that it is the clinician's choice to use local drug delivery agents, and the clinician should base their choice of whether they should use a local drug delivery agent or not based upon few considerations. One is they should look into the clinical findings. Second, they should look into the patient's medical and dental history, look into scientific evidence, patient's preference, whether they are okay with systemic antibiotics or they prefer local drug delivery agents, and also look at the, that is, they have to weigh the advantages, benefits and disadvantages of using alternate therapies over local drug delivery systems. So only when they find that there is a significant advantage of using a local drug delivery in that particular case based on the medical, dental history and scientific evidence, the patient should be prescribed a local drug delivery system. Okay, so basically we can classify local drug delivery agents into either a personally applied local drug delivery agent or a professionally applied local drug delivery agent. What we will be discussing in this presentation will be mostly professionally applied local drug delivery systems. So these are further classified into non-sustained drug delivery. That is, the system is not able to keep the drug at a sustained level. It is not, that is, the drug gets eliminated quickly. So this is a non-sustained drug delivery system and a sustained drug delivery system, which means that the drug is present inside the periodontal pocket for a relative period of time, which can be anywhere from 7 days to 10 days. And this sustained drug delivery is the most efficient type of local drug delivery system because it releases the drug in installments and provides a concentration over an extended period of time. Now, this sustained drug delivery system is further divided into drug deliveries which have a reservoir without rate control. That is, the reservoir of drug is present, it is kept inside the periodontal pocket, but it is usually released in one shot. Okay, so it is effective only for 24 hours. The second type is where the reservoir has a rate control, which means it releases the drug in installments. So within the first 24 hours, it will release maybe 25% or 40% of the drug, and it keeps on releasing it over a period of time. So this is more effective and it lasts for more than 24 hours. So the various available forms for these drug delivery systems are either it can be hydrogel based, oleogel based, or bigel based. Now hydrogel based are usually lipophilic substances, which means that they are water based products. Okay, they help in crossing barriers easily. They are mostly water based. Oleogel based are oil based substances. See, all these drugs, that is the antimicrobial agents, need a carrier. That is, they are incorporated into something else so that they can be placed inside the pocket and the release occurs. Okay, so these are nothing but carriers. So either they can be hydrogel based, that is liquid carriers, or they can be oleogel based, that is oil based carriers, or bigel based, which means a combination of both hydrogels and oleogel, both oil based and water based carriers. So this has the advantage of being able to cross both kinds of barriers, that is hydrophilic as well as lipophilic barriers. And the available forms, that is the forms in which these local drug delivery agents are available, are either as strips, fibers, they can be available as strips, or most often they are available in gel form. So the first one that we are going to see is a chlorhexidine based product. So chlorhexidine, as you all know, is highly active against a broad range of microbial organisms. At lower concentrations, it is bacteriostatic, and at higher concentrations, it is bactericidal. So the main mechanism of action is it disrupts the cell membrane, causing precipitation of the cytoplasm, thereby causing cell death of the bacteria. So as you all know, chlorhexidine usually is prescribed in the form of a mouth rinse. So this mouth rinse usually is given following surgical procedures or as part of maintenance care. Now chlorhexidine based products other than mouth rinses are available as a lot of different formats. That is, they are available in a lot of different formats. They are available as oral irrigators, which are 0.02% chlorhexidine, which is applied once daily, and 100 ml of this is used for plaque inhibition. Then we have gel forms, usually applied in trays. This is effective for oral candidiasis and denture stomatitis. We have chlorhexidine based dentrifices, that is toothpaste, and we have sustained release devices, which are ethyl cellulose or polyethylene glycol based polymers, where chlorhexidine is used as a solvent, and this is mainly used for controlling subgingival microbiota. So these are the general clinical applications. If we look at the subgingival application of chlorhexidine, it is available in gel form and chip form. So the chip form is most commonly used, and it is called as Periochip. It is available in the market. It is a form of targeted controlled release local drug delivery agent, which means that it can target a particular site and it releases in installments. Okay, so this chip is usually a small chip which is around 4 to 5 millimeters in size, and it is composed of a biodegradable hydrolyzed gelatin matrix. Now this gelatin matrix gets cross-linked with glutaraldehyde and it contains glycerin and water, into which around 2.5 milligrams of chlorhexidine gluconate is incorporated. So per chip you will get around 2.5 milligrams of chlorhexidine gluconate. So the advantage of this delivery system is, all of you would have already heard of the term substantivity. So substantivity is a property which is inherent to chlorhexidine, where it provides a proper concentration, that is retainable concentration of a drug over a period of time. So the same is applicable in the case of periochip, where the drug concentrations are maintained for at least 7 days. The drug concentration reaches almost 100 micrograms per ml within the GCF, which is a concentration which is well above the tolerable level for most bacteria, which means that when it reaches such a high concentration, most of the subgingival flora will die. Okay, and these chips are indicated in target sites where the probing depths range anywhere from 5 to 8 millimeters. If the probing depths remain at 5 millimeters even after placing these drugs, then we repeat this therapy once every 3 months. So it is repeated at intervals of 3 months. So this is the picture of how chlorhexidine chip, that is perio chip, is placed inside the sulcus. Okay. So basically after scaling and root planing, the area is isolated and the chip is placed. The advantages of placing a perio chip is, one, it's very easy and convenient to use. It's very highly effective. It is very safe and mostly tolerated by patients. Patients might have minor discomfort within the first 24 hours. Okay, and during a single visit, you can treat multiple quadrants. There is no restriction to eating or oral hygiene procedures after the chip placement. And most importantly, it does not affect the taste sensation or does not stain the teeth. If you see chlorhexidine mouthwashes, the most common side effect is staining of teeth. So this is avoided in periochip, and it maintains a very effective concentration up to 10 days within the periodontal pocket. So the amount reaches anywhere between 100 micrograms per milliliter to 125 micrograms per milliliter. The second variant is called as Periopol CG. This Periopol itself, one is chlorhexidine based, the other one is tetracycline based. So Periopol is available in two forms. One is Periopol CG, which contains chlorhexidine gluconate. Okay, so it's a 10 milligram chip, which is approximately the same size as your perio chip. It is around 4 to 5 millimeters in diameter. It has a collagen matrix into which chlorhexidine gluconate is incorporated. This chlorhexidine gluconate also is about 2.5 milligrams, very similar to your perio chip, and it resorbs within 30 days, but the coronal edge, that is the topmost edge, starts to degrade within the first 10 days. Now this is a sustained release type of local drug delivery system, where during the first 24 hours it releases 40 to 45% of the chlorhexidine, and then linearly there will be a, that is progressive release of the chlorhexidine up to 7 to 8 days. The shelf life of this is 2 years. Now periochip, periopol, all these are commercially available forms. Then we have subgingival chlorhexidine in the gel form. Okay, so this gel form is a xanthan based gel, where it consists of saccharide polymer into which 1.5% chlorhexidine is introduced, and it is available as a 0.5 ml gel. This is like a syringe form, so this is directly injected into the subgingival areas after scaling root planing is done, and then the surface area is cleaned and it is properly isolated. The gel is placed directly inside And as with all these chlorhexidine systems, you just have to give a periodontal dressing. It does not require further care. Okay, and the gel itself contains two types of chlorhexidine. One is a slow release chlorhexidine digluconate, which is 0.5%, and the other is a rapid release chlorhexidine dihydrochloride, which is 1%. So this gel has got two components in it, or two types of chlorhexidine within the system itself. One is a slow release one, and the other is a rapid release one. So the slow release is usually of a lesser percentage, it is 0.5%, whereas the rapid release is 1% of chlorhexidine. So totally, if you see, it comes to 1.5% chlorhexidine. The other two forms, periocol and the periochip, they had 2.5 milligrams. Okay, so this one is 1.5 percentage of chlorhexidine. So this also helps in achieving a high concentration within the GCF, about 100 micrograms per ml within the 6 to 9 days of application, and it maintains the concentration until 15 days. Usually chlorhexidine local drug delivery agents are reapplied once every 3 months. Moving on to tetracycline, this is another form of antimicrobial agent which is very active, and it was the first developed local drug delivery system. It was called as Acticite. Now it is currently, I think, not available, and it has a few disadvantages due to which alternatives were developed. Okay, so this Acticite, it contains flexible monofilaments of ethylene vinyl acetate copolymer. In this copolymer, they have incorporated 12.7 milligrams of tetracycline, and the diameter of this monofilament is around 0.5 mm in thickness. So it's a very thin fiber into which 12.7 milligrams of tetracycline is incorporated for every 9 inches of the monofilament. Now the significant factor about Acticide is it reaches a concentration of almost 1590 micrograms per microliter within the GCF, which is almost 10 times or more than that compared to systemic tetracycline, which only reaches around 4 to 8 micrograms within the GCF or within the periodontal pocket. So such a high concentration causes very profound antimicrobial effect, and these fibers should be placed in close proximity to the base of the pocket. They are packed using a cord packer, and they are secured using any kind of adhesive, preferably medical grade cyanoacrylate. Now the drug is released inside the pocket in installments, just like chlorhexidine. So about 25 to 40% of the drug is released within the first 24 hours, and it maintains the concentration until 10 days. Now after 10 days, this particular monofilament has to be removed. Okay, so it is non-biodegradable, which was the major disadvantage of Acticide. So the fiber had to be removed after 10 days, and suppose the fiber got dislodged within 7 days, it had to be repacked. So to avoid this disadvantage, this is the picture of Acticide. It's a monofilament which is packed in using either you can use a curette or a cord packer. To overcome the disadvantage, they produced another product which is called as Periocol TC. So as I discussed in the previous one for chlorhexidine, this is also called Periocol, but it is called Periocol TC, whereas Periocol CG refers to chlorhexidine. Okay, Periocol TC refers to tetracycline. So this vial, you can see on the right side, this vial contains type 1 collagen. So type 1 collagen, as you all know, is a biodegradable membrane. So this collagen fiber is impregnated with around 2 milligrams of tetracycline hydrochloride, and it is sterilized by gamma irradiation. It releases tetracycline in vitro, that is inside the pocket, for about 8 to 10 days. Okay, and the periodontal dressing should be given after placement of this Periocol TC in order to avoid dislodgement of the fibers. It is usually indicated in adult periodontitis as an adjunct and usually in pockets which are greater than 5 mm. This also can be administered once every 3 months. So prior to placing the fibers are quite tenacious. So we take a few fibers and we place them in saline to soften the fibers, and then we place them deep inside the periodontal pocket after scaling and root cleaning. Okay, and as it has been already discussed, a periodontal dressing is given to prevent the dislodgement of the fibers. Another form of this tetracycline fibers is, I think it might be there in your departments also. Most of you might have seen it as spotters. It is called as periodontal plus AB. This is available in India and it is a bioresorbable tetracycline fiber. It has about 25 milligrams of pure fibrillar collagen. This is also collagen based, so it is bioresorbable and it is impregnated with 2 milligrams of tetracycline hydrochloride. The fibers automatically degrade by the body's degradation process within the periodontal pocket in 7 days, and so they do not have to be removed like acticide. And also it should be retained with a periodontal dressing for about 10 days. While the after the procedure has been done, you maintain the site without dislodgement of the fibers by placing a periodontal dressing. Okay? So it is called as periodontal plus AB. The next one that we are going to see is doxycycline. Doxycycline is available in the form of Atridox. It is also a gel-based solution. It has two syringe mixing systems. So one syringe contains about 450 milligrams of polymeric formulation, and syringe B contains the actual ingredient, which is doxycycline, 50 milligrams of doxycycline. So combined together, it forms about 500 milligrams of a viscous liquid, that is a thick liquid or something like a gel. It contains 10% of doxycycline hyclate. So doxycycline belongs to tetracycline group, as you all know. Another form of doxycycline is used for post-modulation therapy, which is called as Periostat. Okay, so that is available in tablet form. This is a gel form which contains 10% of doxycycline hyclate, and this is mainly advocated in patients who are having chronic adult periodontitis to gain attachment levels and to reduce probing pocket depths. Okay. Now this doxycycline gel, the contents are mixed together into a single syringe and they are directly injected into the periodontal pocket. The entrance of the pockets are sealed by adhesives like cyanoacrylate, that is dental grade adhesives. So they release the drug up to 7 days. Then we have subgingival minocycline. Minocycline is also one antimicrobial agent which has potential antimicrobial activity, and this is called as Arrestin. The commercially available form is Arrestin. Please remember that for doxycycline it is doxycycline. So it's easy to remember. It's called Atridox. For minocycline it is Arrestin. So this is a controlled release delivery system, and it is available in disposable cartridges, each containing 1 milligram of minocycline free base. So this cartridge is disposable, and at a particular time it will provide 1 milligram of the minocycline gel. It is indicated as an adjunct in patients with adult periodontitis, and it has a bacteriostatic effect. It inhibits protein biosynthesis of the bacteria. Okay. And then subgingival metronidazole, this is available as an oil-based gel which contains 25% of metronidazole. It's usually viscous in consistency. Once it reaches the pocket, the body's temperature will cause it to harden. Okay, that is, first it liquidizes. The body's temperature will cause it to liquidize, and then once it comes in contact with water, it will solidify into crystal. So basically gel, sol, and then back to gel form. So initially it is in gel form. Once it contacts the subgingival area, the temperature will make it more liquid in consistency, like a solution. Then it crystallizes back once it contacts water. Okay. So this metronidazole gel is actually produced in its inactive form. and it gets converted inside the periodontal pocket when it comes in contact with esterases, an enzyme which is present in GCF. It gets converted into its active form, okay, which is nothing but metronidazole benzoate. Now, this gel is applied in 1 week interval, that is, two gel, 25% gels are applied within 1 week interval as part of the local drug delivery system. Then you have subgingival moxifloxacin. This is a fourth generation synthetic fluoroquinolone. It's a broad spectrum antibacteria because it's a fourth generation one, and this belongs to fluoroquinolone group of drugs, and it acts mainly by affecting DNA gyrase and topoisomerase 4 of the bacterial cell. So, thereby it produces a significant antimicrobial action against both aerobic and anaerobic bacteria which is present within the periodontal pocket. So, moxifloxacin subgingivally is mainly indicated to treat generalized aggressive periodontitis cases. So, to conclude, local drug delivery systems represent a transformative technological approach that offers precise dosing and also helps to overcome the limitations of conventional modalities. With advances in biomaterials and nanotechnology, now we have found out that local drug delivery systems are not just for infection control. That is, they don't just have an antimicrobial effect, but also they are emerging as an alveolar bone regenerative material. Also, they offer advantage of reduced antibiotic dosage and targeted prolonged release within the disease site. So, this is the latest development in local drug delivery agents. You can add this as part of your that is short notes. Now, with nanotechnology, they have incorporated nanotechnology is nothing but where nanoparticles, particles which are very, very minute. So, they are able to penetrate through bacterial cell membranes very easily. So, these nanoparticles are in that is, they help to carry, they act as carriers for these local drug delivery agents. So, they have developed newer nanoparticles which will help the drug from collapsing. That is the main disadvantage is when you place these local drug delivery agents, the systems sometimes fail, they don't prolong their activity, they get disrupted. But by using these nanoparticles, they prevent this drug disruption. Okay, so they have developed silver gold based nanoparticles. Then this you must have heard, polylactic glycolic acid based nanoparticles. Some of you might be doing even studies on this, chitosan based nanoparticles. All these are carriers for these local drug delivery agents. And now they have also introduced smart hydrogels. As I told you in the beginning, you have different types, that is um, hydrogel form, liquid based forms, which will change from salt to gel consistency based on thermal changes or pH changes. And of course, we have composites and ionic liquids, which will help these local drug delivery agents sustain for a longer period of time and provide the targeted amount or concentration of the drug. Okay. So thank you very much. I have a few videos to show you how the local drug is placed inside the periodontal pockets. I'll just share that if we have time. Dr. Bhuvaneshwari. Dr. Bhuvaneshwari. Hello. Can I show
Yes,
those?
ma'am.
Yes, can I show those videos or is it time up, doctor?
Actually, 3, 5, ma'am.
I'll just run through it.
Yeah,
Maybe
sure,
it's,
sure.
yeah. Is it okay or?
Yeah,
No, it's
just
just the
run through in
placement.
a few minutes, fine, no issues.
Okay, okay.
antimicrobial agent, chlorhexidine. To administer PerioChip, we first remove plaque and bacterial toxins from the infected area with a scaling and root planing procedure. Then we place PerioChip. It slowly disintegrates, releasing the medication, first in a larger concentration, then at a controlled rate for the duration of the treatment. This medication greatly reduces the bacteria in the infected pocket and speeds the healing process. Depending on your needs, we may place up to 8 PerioChips during a single office visit, and we can repeat PerioChip treatment about every 3 to 6 months for as long as periodontal pockets are 5 millimeters deep or more. PerioChip is not an option for you if you are sensitive to chlorhexidine. It's important to know that PerioChip is not a cure for periodontal disease and cannot replace supportive bone loss due to periodontal disease. Reducing the number of periodontopathic bacteria has been demonstrated in clinical studies. Reducing the number of periodontopathic bacteria has been demonstrated in clinical studies. Antimicrobial period. Reducing the number of periodontopathic bacteria has been demonstrated in clinical studies. Antimicrobial PerioChip, easily placed in the periodontal pocket after root surface debridement, contains high concentration of chlorhexidine gluconate and no antibiotics. PerioChip biodegrades within the periodontal pocket, releasing 40% of the chlorhexidine in the first 24 hours. Then it gradually releases the rest of the chlorhexidine in the next 7 days. Over this period, PerioChip not only eliminates 99% of subgingival bacteria in the infected pocket, but also reaches the base of the pocket where the root surface debridement is less effective. For best results, PerioChip should be placed every 3 months as part of periodontal maintenance program, which includes good oral hygiene and root surface debridement. PerioChip is significantly more effective at reducing pocket depth compared to root surface debridement alone. A 2-year study has been shown that almost 60% of periodontal pockets are reduced to less or equal to 5 millimeters, and more than half of them showed a significant reduction of 2 millimeters.
Okay, doctor. That's it. Thank you very much. Dr. Bhuvaneshwari? Dr. Bhuvaneshwari?
Yes, ma'am.
Yeah.
Thank you so much. It was a wonderful lecture as well as and your videos also self-explanatory, and I think the students would have definitely benefited from this. And thank you so much for sharing, spending your time. Thank you so much.
Thank you, doctor. Thank you for the opportunity.
Yes. So today we conclude this series of 2 lectures for the Periodarshan. So we'll continue the lectures tomorrow. Thank you so much.
Sister.